Great, Connie. Thanks so much, and Steve. Really a nice summary. I really enjoyed it. The last speaker before, as Connie said, before our panel is Doug Bruce. Doug is at the Boston University School of Medicine and Boston Medical Center. His career has covered a number of topics, sort of systems of care and outcomes of care, but he's had a long-standing interest in the problems of opioid use and has brought that with him as he moved from Yale to Boston for his current position. He's an associate professor of medicine and will take us through chronic pain and opioid use in older people with HIV. Doug?
Okay, thank you so much, Paul, and thank you everyone for sticking it through to the end here as we talk about pain. So I have no financial disclosures. Your learning objectives are actually in the slide sets that you received, so we won't go through those in detail. And we'll dive right into it. So, when you look at the various studies that have been done, people with HIV have a lot of chronic pain. 39 to 85% of people are experiencing some form of chronic pain. And there are greater rates of both self-reported untreated or undertreated, meaning you're doing some kind of a treatment, but it's insufficient for what the patient is reporting. And a lot of things are associated with this: having HIV, being a woman, having a history of substance use. And if you're in those categories, you have less of or lower probability that you're actually going to get any kind of pain treatment service. Something to say at the outset, and as something to kind of level set our expectations, we will not solve all of the pain problems among people with HIV today, if ever. And so the most important thing to take home today is that pain is very complicated. There is an organic, objective aspect to pain, but there's a really big subjective component. In fact, pain is experienced subjectively. We all experience pain differently, and there are lots and lots of factors such as depression, psychological distress, PTSD, you name it, a bad night's sleep, all impact the perception of pain, which makes it much, much more complicated than this is your HIV viral load and this is the medication and this gets you to undetectable. That's not going to happen so easily in pain. So as we think about evaluating patients with pain, it's always incredibly important, no matter how the patient looks to you in the moment, right? We're always very quick to judge the individual and say, aha, that person really doesn't appear to be in as much pain as I am currently talking to the patient, right? So what happens is that judgment prevents us from validating the pain. So the first thing is, I'm so sorry, Mr. Smith, that you're hurting, right? And then it's a detailed history and examination. And these are the things that when I see people refer to me are often missed. The history was, he said his back hurt, and the physical exam is, well, I mean, what do you do in a physical exam for back pain? And so things don't get done, or they're just kind of transmitted. The last resident, the last fellow, the last attending saw the patient, started them on opioids, and, this is where we're at. So it's really important to do a history and physical exam. The other pieces on here are also really important, and we'll talk more about that as we move along. So you've got a patient. Patient's referred to you. He's 67-year-old. He has a history of heroin injection. He's on methadone maintenance, and he's receiving opioids from his primary HIV care provider. He's been complaining of ongoing pain. His healthcare provider is frustrated with the constant, which hasn't been constant, but in the last 6 weeks, this complaining, thinks it's drug seeking, and sends the patient to you. You could hide out, avoid seeing the patient. People certainly have done that. You could take a history. You could do a physical examination. You could inform the patient that it's really important to keep your pain management with your current provider go away. Or you could just say, well, look, you're on methadone, and whatever's happening with your pain, I can't give you anything. So very quickly, what are people's kind of immediate responses to next steps? And it's pretty intuitive based on what we said. And absolutely. So it's interesting, like several of you said, stay with your current provider of pain management. And that is something we definitely want to think about. But the big thing for this purpose is really a history and physical. And so I saw this gentleman, this is a real case, and he had been having lumbar pain forever, right? He had lots and lots of lumbar pain for years. But in the last 6 weeks, he had developed this new pain. And so when I asked him, where does it hurt? He took his finger, put it in the middle of his back, pinpoint pressure in his thoracic vertebra, which was new. I said, oh, that's kind of interesting. Let's get you imaged. And obviously, right, bad, right? He had discitis. And the thing that was going on here was he had relapsed to heroin injection. That happens for multiple reasons. He'd become transiently bacteremic, seeded his back. But the big message here for all of us to remember is that just because he has substance use doesn't mean that he was drug seeking for opioids and didn't have real pathology. He was actually seeing a provider who that provider didn't examine his back, didn't take a history, blew him off, and this thing sat in his back for way too long. So super important. If someone's coming to you with a complaint of pain, we need to take a pain history. It's often miserable, right? I've never met anyone who said, this is my favorite thing to do when I see a patient is to take a pain history. But it's really, really important. And I've listed some things on here that are just very intuitive and the practical things that we would do whenever somebody comes in with a complaint of pain. And it's just really important to remember these things. It's also really important to know that the pain means lots of different things to lots of different people. And so this is just an example of a patient I saw who said she had 8 out of 10 pain. She's sitting still. She seems fine. Nothing seems concordant. And so I think maybe I need a frame of reference for her. And so I said, have you had children? Yes. If childbirth's a 10, what are you experiencing now? And she said, that's a 2. Right? She had no frame of reference. I asked her to do a scale and abstract. She gave me a number that felt good at that time, but that number didn't have meaning. It had no reference point. So it's really, really important to know who your patient is and to adjust accordingly, right? I had another patient many years ago in the VA, and I'm putting in an arterial line in him. I'm a house officer, and I know this hurts. And he laid there like it was nothing. And I thought, this doesn't make sense. What's his frame of reference? And so I said, sir, I'm really sorry I'm hurting you. And he said, son, you can't do anything to me. I was on the Bataan Death March. So probably not very common among patients, but certainly, again, frame of reference. He was in more pain than he appeared to be. She was in less pain than she appeared to be. I didn't know what the frame of reference was. Make sure you know what that frame of reference is. It's going to help you as you think about your workup, right? For a woman who came in with a pain of 8 out of 10, my differential is bigger. I'm thinking about different things. It's a 2 out of 10. Very different, right? No need for something to be happening emergently. All right. Some of the things that are very important as we think about history, we all gravitate to wanting to do things as expeditiously and efficiently as possible. Many of us live in an Epic world or other electronic health record where we are inundated to enter data all the time, and we are averse to using screening tools because it makes us feel more like data entry clerks. I wish I could tell you I had a solution, but I don't, other than that actually using screening tools is really important because it makes you do the whole thing, right? Otherwise, you're doing an unvalidated assessment for things like alcohol use disorder, which is the audit, or the DAS, which is looking at drug use. Why do we want to think about this? We want to think about this because it influences pain. Maybe it's the cause of what, in my patient, he relapsed to drug use, he had discitis, so it was important to know. Maybe it's something where your patient's drinking more alcohol because your patient's in more pain than he or she is letting you on, and that's driving more problems with the alcohol use disorder. What are the things that are correlated with the drug or pain prescription misuse? Young people play with their drugs. If you have a history of drug use, right? It's always important to remember tobacco use. Tobacco use is a proxy for risk taking. Everyone in America knows that smoking is bad for you. So if you smoke and you know it's bad for you, you're willing to take risks that other people are unwilling to take. And so then by association, another risk you might be willing to take is using your pain medication inappropriately. Family history of drug and alcohol use, obviously, psychiatric history, and then this is likely because drug and alcohol use caused the collision. If you have a history of motor vehicle collisions, you're likely to be somebody who's a misuser of pain medications. Very briefly, when you examine someone, really, really, really think about it clearly. And one key element, the most important element here, is the impact on your activities of daily living. We are not in the business of making people pain-free. We are in the business of trying to help people have sufficient pain control that they can achieve their ADLs. So that's important to level set with the patient. I always talk to patients like, we're not going to solve this problem, right? We're not going to make you pain-free. We're going to try and make it so that you can do X, right? And so that becomes the important conversation. I need to walk 2 blocks to get to the store. I need to be able to walk up a flight of stairs to where I live. I want to be able to walk with my grandson down to the park, right? So setting those things and helping you understand, okay, well, you now have to walk half the distance and stop because of pain. So that now is a marker. My goal is to help you walk a block. You're at a half a block, which is a different goal than I'm trying to make your pain go away. It's certainly critically important for you to document everything that you're doing. I see a lot of charts where patients are on controlled substances for back pain, whatever pain, and there are lots of refills on the chart, and there's not a lot of documentation. If anything goes bad, if the patient overdoses, if something happens, the chart is the record of the event. I encourage you strongly, I can't say it enough, document everything that you're doing. This is a guideline which is now 4 years old, but this is still something that I think is practically useful. And so there's a link there. Take a look at it. It has a lot of just practical, useful things about like what meds have, there's their data and what's useful. So as a patient walks into your office here, you have a 7-year-old gentleman with well-controlled HIV, previously diagnosed with peripheral neuropathy, likely prior to D4T and DDI way back in the day. Been taking gabapentin 603 times a day with unclear relief, right? It's like, I'm not sure if it helps or not. The patient wants some additional pain control assistance, and we're going to assume that you've done a good history, a good physical. What do you want to do for the gentleman, right? So you could increase his gabapentin, right? So he's currently on 1,800 milligrams. You could take him to 24, maybe an SNRI, a tricyclic, maybe smoking marijuana. Maybe you smoke the marijuana and then the complaint of pain is less for you. Trial capsaicin, ALA, or maybe you just say it's time to start an opioid. All right, and so what does our group think? All right, so definitely an increase in gabapentin tends to be the thing that people reach to. The data in gabapentin for peripheral neuropathy isn't very good from a therapeutic perspective. It doesn't really help. What it does do is it makes you really tired. And one of the things that people with peripheral neuropathy complain about is struggling to sleep because of the pain. And so there is some data that if you give higher doses of gabapentin, people actually get better rest. If you're more rested, you may have less pain. The answer I was looking for here is actually capsaicin. The capsaicin 8% patch, which is incredibly difficult to get. It's more painful than many things. Actually has data that if you apply it for 45 minutes, you can get 12 weeks of relief. It's just not something that's easily we're able to get. All right. Something that's super important, we've talked about in the beginning, pain is a combination of this objective phenomenon. So the patient with peripheral neuropathy is having something pathologic and biologic going on with nerve receptors. But that information gets sent to the brain and is processed. So then there's a subjective experience of this organic objective phenomenon. And so that's why when we think about what's the most appropriate treatment, it goes beyond just here's a pill. Now, here's a pill is the easiest thing to do, right? You just write a prescription. But it's insufficient, right? So what happens in the CBT models is CBT does not change the way in which peripheral nerves work. But CBT helps you think differently about the pain that you're experiencing. So think about Lamaze or think about other things where breathing techniques and other things help. They don't extinguish the pain response at all, right? The person's still in serious pain. But the way that their ability to process that changes, and that helps achieve that ADL, right? Being able to feel that you have some power over your pain, that you have a new way of coping with that pain can help you in the experience of pain and help moderate that pain. So other things have been found, for example, acupuncture and yoga. And again, some of this is just how acupuncture is a relaxing phenomenon, although people coming in with me with needles makes me more anxious. And yoga itself is very relaxing. And things that relax, right, decreasing the stress response, help people feel less pain. So that last bullet point was just engage behavioral therapy, right? Make sure, whether it's to get CBT or other things, therapy is very helpful for people. And there are lots of different kinds of therapy, mindfulness and other things that help people think differently about the pain that they're experiencing. You know, when you think about addressing an individual who's in pain, you really have to think about the team that's taking care of them. And so that's going to be the prescriber, the mental health clinician, case management, ancillary support services. Oftentimes, if you have them available, peer support can be very helpful, whether that's a recovery coach, someone who's in recovery, if that person's in recovery, but also somebody who has been experiencing the benefit of improvements in ADLs and has learned the benefits of CBT and other things. You telling the patient they have a benefit has very real meaning, but when they see someone like themselves who's experiencing pain like they're experiencing and see that individual has benefited, that's even more powerful. If you go down the road of opioids, you need to have an agreement. Oftentimes people don't do this systematically across their practice, and that's a result of the biases that we have as people. It's important that it's just structured and systematic and across the board. We always have one provider for, in the clinic assigned to the one patient. Where there may be cross-coverage issues, obviously, it's important, but it's really important that it's not chaotic, that it's not, I can just show up at any time with anyone and get what I want. I think it's really important that we make sure that the things that we're doing get monitored. So urine toxicology, random pill counts, we can talk about other things, but it's really important. We monitor viral load, we monitor AST and ALT, we monitor things all the time, creatinine, we have to monitor substance use. Many times I have heard and I'm so thankful to Jesse Merlin for doing the study, I've heard from so many different people that they keep people on opioids because it keeps them in treatment. It does not. And it's been looked at. You can go to these papers that are referenced here, but it doesn't do it. Again, I spoke earlier about the importance of improving ADLs. That's the real goal. And so that's what your assessment should be, right? Part of monitoring the treatment is not just your urine toxicology, it's how are we doing with your ADL? How's your quality of life? Are there any adverse events being associated with the treatment? Those become really important to be evaluating. It's very, very important to do urine drug testing. You need to know what the limits are of your test. You need to know what the test means or does not mean. I think everyone knows that oxycodone, buprenorphine, fentanyl are all synthetics, and so they don't show up as an opiate unless they're at very high levels. And so it's really important to know what your test is. I see a lot of patients who get in trouble, get tapered off, you name it, get accused of things, and the real issue is a limit in the testing or an inappropriate reading of what the test meant. I'm confident this probably never happened to anyone, right? You've got a gentleman, 65-year-old, who comes in for a refill of his oxycodone. It's 30 milligram tablets. He takes 2 a day every 6 hours for a total of 240 tablets for the month. I use that number because that's the maximum number of opioids the Connecticut Medicaid will give you. You notice there hasn't been a urine tox in 5 years, but he's been getting these opioids. But you do notice that the person's been going to the ED and there's some methamphetamine intoxication that's been listed. The patient's a little agitated today, wonders why in the world this is taking so long. So what do? You curse the person who left you this. You say, I'll give you the refill, go away. I don't want to deal with this. Make sure I never see this person. Call the social worker to deal with this. Or maybe you try to talk with the patient about the emergency department visit and the methamphetamine used to engage interest in treatment and refill the medicine. Or maybe you do that, but you don't refill the medication. So, all right, what does our team think we should do? Right, so a lot of people say, I'm going to talk to them, gauge interest, and refill. And I would say that's probably what most people would do. The one piece of information I didn't give you was if the patient's urine tox in the hospital or in that ED visit had oxycodone or not, right? And what I would say is if the patient did not have oxycodone and an oxycodone screen in the ED and was only positive for methamphetamine, I would not refill that medication. I would not refill the oxycodone. right? They're not taking it. Or they took some of it, but they took it 3 to 5 days ago, right? If the patient had oxycodone in, I would refill the medication, but I'd refill it for fewer days, and I would link it to some form of other intervention. I'm giving you 3 days worth. I want you to come and meet with the social worker and have a conversation about drug treatment or something like that. So it's always important, as we just mentioned, if somebody runs out of medication, right? It could be because maybe they're in more pain. Maybe they had to take more and that's why it's negative. Maybe they drank a lot of water, you name it. It becomes really important to investigate what's going on. Something that's always important, especially if you're sending out the urine, right? So if you get a urine today and you don't get an instantaneous result, document in the chart. Hey, when was the last time you took the medication? Oh, I took my medicine this morning. I've talked to a lot of patients who say, I took the medicine yesterday, I took it today, I get the urine tox back, it's negative. I say, what happened? Oh, I was in more pain, I missed doses. On the day that you saw me, you said you took the medicine. So my concern is that either you were not honest with me then, or you're not honest with me now. But honesty is really important if you're going to continue on opioids, right? So being able to have that information is very helpful when you confront the patient if there's an issue in the future. So here's a 60-year-old who comes into clinic, and as you can imagine, through much creative and interesting conversations, you conclude that the oxycodone you were giving for back pain is not in the urine, but morphine is. Morphine is the metabolite of heroin. So you refuse to refill the medication, let somebody else deal with it, agree that the patient that it was probably just a one-time use of heroin. I'll give you some more oxycodone. Discuss treatment for opioids, start bup. Discuss treatment for opioids, refer to methadone, or treatment for opioids and start naltrexone. All right. And what does our group say here? Fantastic. Great. So buprenorphine is a great answer here. It's the one opioid that you can do in primary care where for substitution therapy. The problem is that the person's got to be in withdrawal for you to do it. Methadone is a fantastic medication, has better retention and treatment than buprenorphine, and can be started if the person's not in withdrawal and if they've recently used, but can't do it in primary care. Naltrexone, the big problem here is the person needs 7 days of sobriety before they start naltrexone, which is difficult and is often used more in correctional settings as people are discharged. And Sandy Springer has done some great work on that. This is just the summary of why do we do buprenorphine, why do we do methadone? It takes in that first top row there of bup 0, all of those pretty colors in the brain, which are vacant mu-opioid receptors. We fill them all up. And when you fill up those, as I tell my patients, we filled up the parking lot. Heroin can't get to into those parking spaces, and it helps promote sobriety. It doesn't fix the problem, but it helps make things better. As we wrap up, I've listed here kind of, what are the things that you can do with a urine drug test, whether it's positive, negative, what are some of the things to think about? I think that it's really, really important to think about mental health disorders as a confounder, both for pain and for substance use. Screen for it, think about it, work with your colleagues on it. It's very important. A lot of times this gets missed and the patient suffers as a result. Always keep a high bar there. Really think about the history of physical or sexual violence. Sometimes the pain someone's experiencing is really due to intimate partner violence, and I've seen that get missed, and it's really tragic. Pain and addiction are different, so just be mindful of that. Our discussion today is on pain, but I leave this for your reference as you think about these two things that overlap far too often. We're going to skip over the polling aspect of this just because of time, but this is actually all of the above is the answer here. All of these things can be things that really look like aberrant behavior. And so it's just really important that as a patient acts out in clinic or does something, it could mean a lot of things. Maybe the person's as they're aging, they're getting confused. Maybe there's a component of dementia. Maybe they're encephalopathic. Maybe their hep C got treated, but their liver disease progressed, and now they've got hepatic encephalopathy. So just remember that just because the person comes in and is on pain meds and has chronic pain, and just because they're being annoying today, doesn't mean that there's not some other really important process going on. Make sure that you don't make a big mistake by being dismissive, as that provider did a long time ago, just assuming, oh, he's got back pain, he's a heroin addict, there's nothing going on. There was something serious going on. If you're in an academic medical center, you're going to have access to consultation, but just make sure that you have colleagues to talk to. My email's at the end of this. Feel free to shoot me an email anytime. But don't feel like you're alone. Don't be alone. There's some additional URLs here at the end that really connect you to some other resources. In conclusion, pain is prevalent. It's complicated. It is a big challenge as we try to address it. When we address it, it should be multimodal, not just one thing, a little CBT, a little medication. It needs to be multidisciplinary, peer support, nursing support, therapy, all kinds of things. And if you're doing any kind of treatment, it should be monitored. Make sure you don't miss mental health and substance use. It's out there. It's prevalent in our population. People with HIV got HIV because they took risks that others were not willing to take. And in that risk taking, substance use and mental health play heavily. Don't miss it. It's really important for us to think about those things to avoid missing important causes and complications of pain. Thank you so much for bearing with me through the mad dash at the end of the day. My email's here. Please feel free. I'm sure we'll have a good conversation in a little bit, but feel free to email me any questions. And Paul, back to you. Here are some of the websites I mentioned.
Yeah, great, Doug. Thanks. That was a great review of obviously a very important thing. I was thinking as you were talking that, if I go back years, I think we've come a long way in our understanding of pain, and the options that you suggest are really important ones for us to know about. I guess we have a number of questions. You did mention tramadol. I've found that can be a kind of a little bit of a bridge between opioids, and it's got some SSRI as well. Can you comment on that?
Yeah, absolutely. I think tramadol can be very helpful in a certain set of populations. A lot of the people that I'm taking care of who are longtime heroin addicts, I mentioned tramadol and they roll their eyes, and it's kind of a non-starter. But certainly for many people, it can actually be something that's very helpful, and definitely something that to do before you're jumping off and doing oxycodone or something.
So one participant says on your second pain poll, he would have started paracetamol. What's your thought about that?
Yeah, so I think it's a really good point. So one of the things that's really complicated. So if that's the patient with the peripheral neuropathy, I listed the things that had data that had been studied in peripheral neuropathy, and so that may be helpful, but it tends to be in people with really painful peripheral neuropathy not to be that helpful, and so that's why it wasn't up there.
Great. A couple questions from the same participant about methadone. Thoughts on methadone for pain, and will the regs change so that it can be used in a primary care setting?
So I'll take the second first. The regs won't change because we have I think an unnatural fear of methadone. It was originally done as a pain medication, and it has very good pain properties. It needs to be dosed more than once a day. The once a day dosing is for the treatment of an opioid use disorder. But methadone that's broken up in the kind of 3 to 4 times a day is very helpful for pain. It can be done off label in primary care, but it requires a great deal of supervision, overdose risk, etc. Some technically an opioid treatment program can split dose methadone for your patient who is a heroin user on methadone maintenance but struggling with pain, and that's something certainly to talk to a methadone clinic about. They can get what are called exception orders from the federal government for split dosing, and that's a great way if you think this patient's on methadone, this patient would really benefit from being able to take some of an opioid at night. I don't want to be the one giving that person an opioid at night. A methadone clinic can do that. A lot of them need to get pushed to do it, because it's extra work.
Super. Thoughts about THC and CBDs for pain?
Yeah, so some of the studies that have been done in this there's a selection bias, right? So they took people who were smoking marijuana and then randomized them relative to the dose of marijuana to find out if they had a benefit. And so the real question people want to know is, if I have a patient who has never smoked marijuana or used CBDs and I give it to that person, will they benefit? And the answer is, we haven't done that study. One of the concerns has been that the cannabinoids do have a risk of seizure and neurocognitive effects. So if you think about the synthetic cannabinoids like K2 and spice that have caused kind of quote unquote overdoses where people become catatonic briefly, there's just been a concern relative to harm. And so I think where a lot of folks come down on this is, if your patient is already using marijuana or has a history of marijuana use and has not had any kind of psychosis or psychiatric reaction to that, then it's probably okay to say, do what you need to do to feel better. For those who have not, some will talk about doing CBDs or CBD oils because of the lower risk. But a lot of people in the pain world are concerned about just recommending to go out and start smoking marijuana or other use of synthetic cannabinoids because of the neuropsychiatric risks.
Great. We have some other really good questions. We can hold those for the panel, which is to follow. And Doug, thanks again so much. Really, really important, helpful talk that you gave us. So thanks very much. And Connie, maybe I'll toss it to you. We haven't exactly coordinated our moderation of the panel, but you want to start that off?